Hey guys, welcome to Conditions with Molly. Back again with a continuation of the cardiovascular system. Today we're going to be speaking about angina pectoris, which is an ischemic heart disease. This condition is characteristic chest pain less than 15 minutes due to myocardial infarction. The pathophysiology behind this condition is that there is subendocardium ischemia, which triggers the release of adenosine and bradykinin, which is going to result in vasodilation that further leads to decreased blood pressure and increased vascular permeability, therefore causing pain, sensation, and edema or swelling. This condition is found in 1 out of 10 patients that are more than 65 years old, but it's more common in males. The risk factors or causes for this condition are atherosclerosis, ischemic heart disease, anemia, valve disease, illicit drugs, hypertension, diabetes, obesity, smoking, dyslipidemia, coronary vasospasm, and there is a few more causes that I didn't name. The signs and symptoms, we're gonna have chest pain with ECG. With E standing for exercise, the chest pain is going to be worsened by exercise. C standing for constricting chest pain, which radiates to the neck, shoulders, or arms. Then G stands for glycerol trinitrate, which means the patient's chest pain is going to be relieved by nitrates. In the same instance, we also learned that except for nitrates, rest also provides relief within 5 minutes. So we have ECG. If the patient has 3 out of 3 of those things, the patient has a typical angina. If the patient only has 2 out of 3, it's an atypical angina. And if it's 1 out of 3, it's not an angina at all. As I already said, the chest pain is worsened by exercise and relieved by rest. With your investigations, your ECG may or may not have Q wave or ST to T changes. With your blood, you're going to do an FVC to rule out a low HB, therefore rule out anemia. You're going to check your troponin to check if it's not a myocardial infarction. You're going to do your UNE. You're going to do your CT coronary angio. You also can do an exercise ECG to check if the patient's chest pain is exacerbated by exercise. You also have to do your CKD risk factor assessment. You're going to check the blood pressure, you're going to do the lipids, and you're going to do glucose levels. And just like our myocardial infarction, our angina also has 2 types. It has a stable angina and unstable angina. A stable angina is caused by predictable factors like exercising or stress, and it's often related to atherosclerosis. Then our unstable angina, the pathophysiology comes as there is decreased blood flow in the coronary arteries, resulting in no muscle function at all. Our unstable angina is caused by unpredictable factors like blood clots or plaque rupture. And as I already said, the chest pain in angina is less than 15 minutes, but in an unstable angina, it's gonna be more than 10 minutes. And you will notice that nitrates do not provide any relief. This condition is a medical emergency because if untreated, it leads to an NSTEMI, which is a non-ST elevation myocardial infarction. Going to our treatment, in this instance, we don't immediately admit the patient, but our non-drug treatment is smoking cessation, decreasing alcohol intake, decreasing stresses, going on a diet, and exercising 40 minutes 3 times a week. Drug algorithm, we have the pneumonic cider, which I made up myself. We have our aspirin. We have our organic nitrate, which is an isosobate dinitrate. We have our beta blocker, which is atenolol, and we have simvastatin. And if it is an unstable angina, we are gonna give the patient oxygen, 40% BVM. With our complications, there's always heart failure and arrhythmias. Then we have acute coronary syndrome, myocardial infarction, cardiac arrest, anxiety and depression, and also we're gonna have decreased life quality. Again, thank you for listening, guys. This is Conditions with Molly. Like and subscribe, and the comment section is always open for questions.